Gastroenterology. Input 1, Upper gastrointestinal tract. A 40-year-old male with no known comorbidity complains of easy fatigability. He claims to have poor quality sleep because he is frequently awakened by throat discomfort that leads him to be continuously coughing. He was apparently well about 3 months ago until he was laid off from work and began taking 4 to 5 bottles of alcohol daily. BP equals 130/80, CR equals 87, RR equals 22, BMI equals 35. He is clinically anemic. Other findings are non-contributory. What is the most likely diagnosis? 2 or more episodes per week of frequent or severe reflux symptoms sufficient to impair the quality of life. The major clinical presentation is GORE. Other presentations include dysphagia, night coughing, easy fatigability from IDA, recurrent respiratory infections, hoarseness of voice, halitosis, and loss of enamel from teeth. The severity of symptom does not accurately predict the presence and severity of ulceration. Focus: all of the following is true regarding this condition except, etiology is unknown in most cases. It is associated with Western lifestyle. The lower esophageal sphincter plays the most important role in preventing reflux. Many patients have an esophageal motility disorder leading to reflux. Contrary to belief, there is a poor association between GORD and hiatal hernia. Both loss of or low tone and esophageal motility disorder may be a cause or a consequence of GORD, but certainly a perpetuating factor. Focus: to investigate his condition further, which of the following is the most appropriate advice? Observe patient's condition with more frequent follow UPS. B. Refer him for endoscopy. C. Do 24-HR esophageal pH monitoring. D. Initiate empiric treatment for H. pylori. If with typical heartburn symptoms, approach with proto, pum, inhibito, and lifestyle modification, then observe. If with a typical symptoms, i.e., anemia, dysphagia, or odynophagia, hematemesis and/or melena, vomiting, weight loss, new symptoms in the elderly, changing symptoms, severe or frequent symptoms, or if there's failure of pharmacologic and non-pharmacologic management, do endoscope. Why? First, if with erosive esophagitis, start oral proton pump inhibito. If with normal findings, continue monitoring while on empirical PP. If with abnormal morphology, biopsy sample. Focus: endoscopy would most likely show normal esophageal mucosa, erosive esophagitis with areas of ulceration, stricture formation, the squamous mucosa replaced by columnar cells. Findings consistent with malignant transformation. Majority have normal esophageal mucosa, some with erosions, circumferential ulcerations, and/or neoplastic changes, Barrett's esophagus or malignancy. Focus: the most common complication of GORD is adenocarcinoma of the esophagus. B. Stricture formation. C. Chronic respiratory infections. D. Bronchial asthma. E. Chronic blood loss. The two most important complications are esophageal stricture and B. Barrett's esophagus. Focus: the most appropriate treatment for his case would be A. Lifestyle modification including weight reduction. B. Medical therapy with antacids, H2 blocker, and/or PPI. C. Refer to surgery for fundoplication. D. Combined medical and surgical approach. Depends on the severity. For mild intermittent symptoms, start with diet and lifestyle modification. Low-fat diet and moderation in consumption of alcohol, coffee, chocolate, citrus fruit, tomato products, spicy foods, and carbonated beverages. Eating smaller meals, drinking fluids mostly between meals rather than with meals, avoiding lying down and doing activities that increases abdominal pressure immediately after meals, elevating the head of the bed, smoking cessation. On-demand drug therapy include antacid plus alginate preparation 10 to 20 ml orally as needed, or magnesium hydroxide plus aluminum hydroxide preparation 10 to 20 ml orally as needed. If antacids are inadequate, use an H2 receptor antagonist, example famotidine 20 mg orally once or twice daily as needed, or nizatidine 150 mg orally once or twice daily as required, or ranitidine 150 mg orally once or twice daily as required, or a proton pump inhibitor at the standard dose orally once daily 30 minutes before a meal as needed, example esomeprazole 20 mg, lansoprazole 30 mg, omeprazole 20 mg, pantoprazole 40 mg, rabeprazole 20 mg. For frequent or severe symptoms, in addition to diet and lifestyle change, pharmacologic therapy include: use a proton pump inhibitor following the standard dose above for 4 to 8 weeks, then step down to prevent rebound hypersecretion, example having the dose of the proton pump inhibitor, or using as needed or regular therapy with an H2 blocker or antacid. Proton pump inhibitors are generally considered safe even for long-term use, always re-evaluated, but have been associated with short-term, example interstitial nephritis, and long-term, example hypomagnesemia, increased risk of pneumonia, Clostridium difficile and other gastrointestinal infections, impaired nutrients absorption, risk of fracture, adverse effects, including possible interactions with thienopyridines or increased risk of cardiac events. If with severe complications such as dysphagia from stricture formation or recurrent respiratory infections, surgery is entertained. Nissen fundoplication. The fundus of the stomach is drawn around behind the esophagus and stitched to itself in front. Barrett's surveillance. Endoscopic/histological finding. Short segment Barrett's, and LT3CM, no dysplasia. Surveillance interval/recommendation. 3 to 5 years. Long segment Barrett's, superscript 3-3cm, no dysplasia. 2 to 3 years. Barrett's low-grade dysplasia, LGD. 6 months. If LGD persists, consider referral for endoscopic therapy, otherwise, repeat endoscopy every 6 months until clear of dysplasia. Barrett's high-grade dysplasia. Immediate referral for endoscopic ablation. Barrett's indefinite for dysplasia. 6 months. Early adenocarcinoma, confined to mucosa. Immediate referral for endoscopic treatment. Invasive adenocarcinoma. Surgical referral. Barrett esophagus is a premalignant condition, i.e., metaplastic columnar epithelium replaces the stratified squamous epithelium, usually a complication of long-term GORD. Endoscopic surveillance is the standard of care. Aim of treatment is to control reflux and therefore reduce its complications, i.e., use of proton pump inhibitors. Proton pump inhibitors results to regression of Barrett esophagus but not necessarily reduce progression to adenocarcinoma. Testmanship. A 35-year-old female seeks consult for progressive dysphagia to both solids and liquids. Initial chest X-ray showed absence of gastric air bubble with a tubular mediastinal mass beside the aorta. Subsequent fluoroscopy with barium swallow showed a persistent beak-like narrowing in the terminal esophagus. What is the most likely diagnosis? Achalasi. This disorder is due to intramural inhibitory neurons. Dysphagia, chest pain, and regurgitation are the main symptoms. On chest X-ray, as stated. On barium swallow, there is esophageal dilation or sigmoid appearance. On fluoroscopy with barium swallow, as stated. Manometry shows normal or elevated basal lay pressure, absence or reduction in the degree, duration and consistency of swallow-induced relaxation of the LES, and elevated esophageal body resting pressure. The aim of treatment is to reduce the pressure in the lower esophageal sphincter to relieve obstruction. If symptoms are mild, smooth muscle relaxants may be trialed. Medical treatment: nitrates, calcium channel blockers, sildenafil, Endoscopic intrasphincteric injection of botulinum toxin every 3 to 12 months. Surgical treatment, balloon dilatation, Heller's extramucosal myotomy, procedure of choice, peroral endoscopic myotomy. Blank. 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 With barium swallow, the blank. With barium swallow, the normal sequential peristalsis below the aortic arch is replaced by uncoordinated simultaneous contractions that produce the appearance of curling or multiple ripples in the wall, saculations, and pseudodiverticula corkscrew esophagus. For an acute attack, medications include glyceryl trinitrate spray 400 mcgs sublingually as needed or glyceryl trinitrate tablet 600 mcgs sublingually as needed. Blank. Peak ages of incident. Clinical features. Achalasia. Peak ages of incidence in young adulthood, idiopathic, and old age, mostly degeneration, slowly progressive dysphagia, initially worse for fluids than solids, frequent regurgitation of undigested food common in late disease, secondary recurrent respiratory infections due to aspiration. Diffuse esophageal spasm, commonest in young adults, characterized by acute pain along the length of the esophagus induced by ingestion especially of hot or cold substances, odynophagia. Video barium swallow, rat tail or bird beak, failure of relaxation of the lower esophagus with a smooth outline. Diffuse esophageal spasm, corkscrew caused by uncoordinated contractions. Esophageal monometry. Achalasia. Hypertonic lower esophageal high pressure zone with failure of relaxation normally induced by swallowing. The proximal esophagus may be adynamic in chronic cases. Diffuse esophageal spasm. Diffuse hypertonicity and failure of relaxation, little or no evidence of coordinated progressive peristalsis during episodes but normal peristalsis when asymptomatic. Esophagoscopy. Achalasia. To exclude benign and malignant strictures. Diffuse esophageal spasm. Required to exclude underlying malignancy. To know. Nice. To know. Benign tumors of the esophagus. And LT 1% of all esophageal neoplasms. The most common is leiomyoma. Rare entities include papilloma, fibrovascular polyps, granular cell tumors, adenomas, hemangiomas, neurofibromas, and lipomas. Leiomyoma. Smooth muscle tumor, usually solitary, slowly growing, well encapsulated with intact overlying mucosa. Mostly an incidental finding and so asymptomatic, and LT5-CM. Diagnosis by barium contrast study and endoscopy. Rarely becomes malignant. If small and asymptomatic, observe. If large, and GT5-CM, surgical removal by simple enucleation or esophageal resection. Pharyngeal pouch. Common in the elderly and is associated with lower cranial nerve dysfunction. Presence as upper cervical dysphagia, intermittent lump appearing to the side of the neck on swallowing, and regurgitation of undigested food. Diagnosis by observed swallowing with transient neck swelling. Video barium swallow shows filling of the pouch. Treatment with endoscopic stapled pharyngoplasty, side-to-side stapling of pouch to the upper esophagus. Hiatus hernia. May or may not be associated with GORD. Obesity and previous surgery are predisposing factors. Sliding hernia results from axial displacement of upper stomach through the esophageal hiatus, usually with stretching of the phrenicoesophageal membrane. Most common form. Result in GORD. Hiatus hernia results from the displacement of part or all of the fundus and body of the stomach through a defect in the phrenico-esophageal membrane such that it comes to lie alongside the normal esophagus. Less common symptoms include hiccup, pressure in the chest, odynophagia, blank. Testmanship. A 55-year-old male complains of progressive dysphagia for 3 months. Fluid remains to be tolerated but not with solid foods. He has been living alone for 10 years now after his wife died and his children left him. He also reports weight loss although unquantified. Just this morning, he noticed his stools to be blackish and foul-smelling. He denies any abdominal pain/discomfort but notes episodes of choking in the past. What is the most likely diagnosis? Esophageal cancer. It is the 8th most common cancer in Australia. Adenocarcinoma is the most common histologic type. Are the most common etiologic agents. Patients with other aerodigestive malignancies have a 5 to 8% risk of developing synchronous or metachronous esophageal squamous cell tumors due to similar exposure and field cancerization. To know. Factors associated with the pathogenesis of esophageal cancer: environmental, smoking, alcohol consumption, hot beverages, N-nitrosocom, betel nut chewing, deficiencies of green vegetables, vitamins A, C, and E, niacin, riboflavin, beta, carotene, zinc, molybdenum, history of radiation to the mediastinum, low socioeconomic class, obesity, fungal toxin or viral infection, specific conditions, history of aerodigestive malignancy, achalasia, like erosive stricture, Plummer-Vinson syndrome, tylosis, Barrett's esophagus. Focus: you know that all patients with dysphagia must be investigated to rule out malignancy, thus, you require the patient to undergo which of the following initial investigation? A. Barium swallow. B. Endoscopy. C. Neck ultrasound. D. CT scan. Barium swallow identifies the location and narrowing, mucosal irregularity, dilatation of the proximal esophagus, and the shouldering impression. Blank. T. Primary tumor. TX tumor cannot be blank. Stage groupings for esophageal cancer. T. Primary tumor. TX tumor cannot be assessed. Tis in situ carcinoma. T1 tumor invading lamina propria or the submucosa, does not breach the submucosa. T2 tumor invading into but not beyond the muscularis propria. T3 tumor invades the adventitia but not the adjacent structure. T4 tumor invades the adjacent structure. N. Regional lymph nodes. NX regional nodal status cannot be assessed. N0 no regional nodal involvement. N1 regional lymph node involved. M. Distant metastases. MX distant metastases cannot be assessed. M0 no distant metastasis. M1 upper thoracic esophagus with metastases to cervical nodes. Lower thoracic esophagus with metastasis to coeliac nodes. M1b upper thoracic esophagus with metastases to other non-regional nodes or other distant sites. Lower thoracic esophagus with metastases to other non-regional nodes or other distant sites. Middle thoracic esophagus with metastases to cervical, coeliac, other non-regional nodes or other distant sites. Stage 0. Tis. N0, M0. I. T1. N0, M0, IIA. T2, N0, M0, T3, N0, M0, IIB. T1, N1, M0. T2, N1, M0, 3, T3, N1, M0, T4, N0 N1, M0, EVA, NET, NEN, M1A, IVB, NET, NEN, M1B. Treatment algorithm. Focus, endoscopy showed the tumor extending between 27 cm to 34 cm from the upper incisors. Which procedure is most likely to be performed? Lewis-Tanner operation. Extended total gastrectomy with distal esophageal resection. C. Proximal gastric and distal esophageal resection. D. McKeown's procedure. The cervical esophagus extends the cervical esophagus extends from the cricopharyngeus muscle at C6 level to the thoracic inlet. 15 to 18 centimeters. From the upper incisor, the upper 3 of the intrathoracic esophagus extends from the thoracic inlet to the tracheal bifurcation, 20 centimeters. The middle 3 includes the proximal half of the esophagus between the tracheal bifurcation and the diaphragmatic hiatus, the lower third being the distal half of the segment. The junction between the middle and the lower 3 corresponds to 30 centimeters from the upper incisors. For tumors of the middle and lower 3 of the esophagus, the most often performed procedure is the Lewis-Tanner procedure. In type 2 and 3 tumors around the gastroesophageal junction, an extended total gastrectomy with a distal esophageal resection is often performed, although some advocate a proximal gastric and distal esophageal resection. In tumors of the upper thoracic esophagus, McKeown's procedure is usually performed. Focus, of the following, which is the most common complication of esophagectomy? Myocardial infarction, atelectasis, renal failure, anastomotic leak, perioperative hemorrhage. Complications after esophagectomy: medical, cardiac, atrial arrhythmia, myocardial infarction, cardiac failure, pulmonary, atelectasis, pneumothorax, bronchopneumonia, sputum retention, pleural effusion, pulmonary embolism, respiratory failure, other medical, renal failure, hepatic failure, stroke. Surgical, hemorrhage, tracheobronchial tree injury, recurrent laryngeal nerve injury, anastomotic leakage, gangrene of conduit, intrathoracic gastric outlet, obstruction or gastric stasis, bowel herniation, chylothorax, empyema, wound infection. Something interesting. 3 centuries ago, a Dutch physician described the case of a Grand Admiral of Holland, Baron Wassenaar, who complained of severe chest pain and exclaimed that something had burst in his chest. The admiral had consumed a huge meal, had taken a self-prescribed emetic, and shortly afterwards he vomited, but only a little, and this not easily. What is the likely cause? Bauer-Have syndrome. Mackle, triad. The classic presentation of spontaneous esophageal rupture is that of a middle-aged man with a history of dietary overindulgence and overconsumption of alcohol who experiences chest pain and subcutaneous emphysema after recent vomiting or retching. Hammond, triad. This is the combination of subcutaneous emphysema, rapid respirations, and abdominal rigidity. Has the highest mortality rate. The intrathoracic esophagus is the most common site of esophageal perforation, followed by cervical and intra-abdominal. Atrogenin is the most common etiology, EGD, but Bauer-Have syndrome has the highest mortality rate. Instrumental perforation is common in the pharynx or distal esophagus. Spontaneous rupture may occur just above the diaphragm in the posterolateral wall. Perforations are usually A. longitudinal, B. transverse, and is more common in the A. right, B. left. The absence of serosal layer in the esophagus makes it more vulnerable to rupture or perforation. Treatment as for indications for surgery, clinical instability with sepsis, recent post-emetic perforation, intra-abdominal perforation, absence of medical contraindications to surgery, mediastinal leak, malignancy, and obstruction or stricture in the region of the perforation. Treatment as for upper GI perforation. Testmanship. A 75-year-old female comes to surgery for chronic abdominal pain that is mostly occurring early in the morning but is immediately relieved by breakfast. She is also suffering from chronic low back and knee pain that increases her disability. At times she notes dark-colored foul-smelling stools. What is the most likely diagnosis? Peptic ulcer disease. Classic sites involved. Stomach. Proximal duodenum. The most important factor in the causation of the ulcer is H. pylori infectia, ulcer with severe burns, curling sulci. Ulcer with head injuries, Cushing ulcer. Duodenal ulcer. Clinical features. More common. Higher incidence in younger, male patients. Mostly in the duodenal bulb. Cardinal symptom epigastric pain 2-3 HP. Localized in the epigastrium, dull or burning, starts several hours after a meal, wakes the patient at night and is relieved by food. Gastric ulcer. Clinical features. Less common. More common in the elderly. Mostly in the angular incisura. NSAIDs are a common cause. Most common symptom, epigastric pain IMM. P. Exacerbated by food. Nausea, unremitting pain, and weight loss are common. Duodenal ulcer. Diagnosis. Barium meal. Most accurate, e.g. D. Diagnosis of H. pylori, urea breath test. Stool antigen test. Endoscopic biopsy. Gastric ulcer. Diagnosis. Barium meal. Endoscopy. Biopsy. Treatment. Goals of treatment. Medical. Antacids. H2 blockers. PPIs. Coating agent. Antibiotics surgery. Polyos gastrectomy. Truncal vagotomy and drainage. Selective vagotomy. Vagotomy and antrectomy. Gastric ulcer. Treatment. Medical treatment as with duodenal ulcers surgery. Bilirubigastrectomy. Excision with vagotomy and pyloroplasty. Nice to know. Zollinger-Ellison syndrome. Due to hypergastrenemia causing extensive, persistent, or typical ulceration. Benign secretory gastrinoma, usually intrapancreatic, or malignant gastrinoma associated with Men's syndrome. Diagnosis, raised serum gastrin level, CT scan, angiography, selective pancreatic venous cannulation at surgery. Treatment, resection of pancreatic tissue. 5 main indications for endoscopy. If a change in management is probable on the basis of endoscopy results. After an empiric trial of therapy for a suspected benign digestive disorder has been unsuccessful. As the initial method of evaluation as an alternative to radiographic studies. When a primary therapeutic procedure is contemplated. Presence of alarm symptoms. Indications for GI biopsies. Detection of lesions, polyps, cancer, ulcers, Barrett's, esophagus. Obvious inflammation. No obvious lesions, but to confirm/exclude coeliac disease. Suspected infection. Follow-up of cancer or polyps. Drugs and GIT biopsy findings. Drug. NSAID, corticosteroid. Olmesartan. Iron tablets, anthranoid laxatives, including senna. Ipilimumab. Biopsy findings. acute inflammation, reactive changes, nonspecific erosions, and ulcerations. Lymphocytic gastritis. Gastric erosions with iron pigment deposition. Mimics coeliac disease. Testmanship. A 72-year-old male immigrant comes to surgery for chronic abdominal pain, bloatedness, and weight loss of 18 kilograms since the previous 6 months. He has been living in Japan for the past 30 years and had always felt well until about year when he migrated to Australia that he started feeling all these symptoms. Pertinent findings in the physical examination are palpable lymphadenopathias in the left supraclavicular area and direct upper abdominal tenderness. What is the most likely diagnosis? Gastric C. 90% of the adenocarcinoma subtype, others are lymphoma and stromal tumors. Mean age at presentation is 70 years with is a 2:1 male to female predominance. More common in the antrum before, but recently seen most commonly in the proximal third. Key identified etiologic factors for non-cardiogastric cancers. Pylori infectio. Genetic. Di. Cigarette smoking. Focus. What is your most appropriate next step? Perform endoscopy and biopsy. Request for baseline upright abdominal X-ray. Request for whole abdominal CT scan with triple phase contrast. Refer to palliative care for this is most likely an end-stage disease. Nice to know. Staging is achieved with helical CT scan and endoscopic ultrasound. Stage groupings for gastric cancer. T. Primary tumor T1 tumor in mucosa or submucosa T2 tumor into/through muscularis propria T3 tumor through serosa T4 tumor invades other structures N. Lymph nodes, requires at least 15 nodes to be examined, N0 no nodal involvement N1 1 to 6 nodes involved N2 7 to 15 nodes involved N3 and GT 15 nodes involved M. Distant metastases M0 no distant metastasis M1 distant metastasis. Stage T N M0 TIS N0 M0 T1 N0 M0 IIA T2 N0 M0. 5-year survival rate for stage I4 tumors are approximately 90%, 60%, 30%, and 5%, respectively. Focus. A 55-year-old female was diagnosed to have AT1 gastric cancer. What is the treatment of choice? Chemotherapy, endoscopic mucosal resection, surgical resection. Observe and repeat gastroscopy after 6 months. Options for treatment include endoscopic mucosal resection and either partial or complete gastric resection with anastomosis. Early and late complications. Early usual cardiac, respiratory and wound complications anastomotic leak suture breakdown fluid collection/abscesses acute pancreatitis prolonged nasogastric drainage or vomiting. Blank. Treatment algorithm. Gastric lymphoma. Most arise from MALT rather than LNS. Mostly B-cell, some T-cell. Occur in response to chronic inflammation secondary to H. pylori infection. Diagnosed by endoscopy/biopsy and stage by EUS and CT scan. Low grade, eradication of H. pylori, 70–100% resolution, chemotherapy if unresponsive. High grade, chemotherapy. Surgery is reserved for the treatment of tumor or treatment-related complications. Gastric cyst. Stomach is the most common site. Mesenchymal tumors that arise from the interstitial cells of Kajal. Present as elevated submucosal swellings that ulcerate or bleed. Spread by local invasion and hematogenously. Diagnosed by endoscopy/biopsy and staged by EUS and CT scan. Treatment is by surgical resection. Gastric polyp surveillance. Type: fundic gland polyp. Surveillance: no dysplasia, no follow-up dysplasia, consider FAP and perform colonoscopy. Hyperplastic polyp: repeat gastroscopy in 1 year, test and treat for H. pylori. Adenomatous polyp. Blank. Incomplete resection or high-grade dysplasia, HGD, repeat gastroscopy in 6 months, complete resection and no HGD, repeat gastroscopy in 1 year. Blank. Gastric or duodenal ulcerations. Esophageal varices. Esophageal ulcerations. Risk associated with agents affecting mucosal health and worsening risk of bleeding. General measures: immediate resuscitation, establish the diagnosis, request for appropriate exams, give 4 PPIs, discontinue NSAIDs/antiplatelets/anticoagulants, blood/blood component transfusion, surgery if warranted. Indications for surgery: massive hemorrhage requiring ongoing resuscitation, failed initial endoscopic treatment, rebleeding not suitable for repeated endoscopic treatment. Definitive treatment: varices, endoscopy, coagulation, banding, for vasopressin, interventional radiology or surgery. Gastric/duodenal ulcer, endoscopic coagulation or injection, local excision or partial gastrectomy. Gastric carcinoma, see algorithm. Esophageal trauma, oral antacids. Aortointestinal fistula, surgery if patient survives from diagnosis. Upper gastrointestinal perforation. Acute onset upper abdominal pain that is severe, constant, and worse with breathing or moving. Copious vomiting and upper abdominal distension suggest volvulus. Prodrome of weight loss, dyspepsia, and anorexia suggests carcinoma. Signs of peritonitis. General measures, similar to UGIB. Definitive treatment, depends on the cause but is mostly surgical except when the patient declines, considered unlikely to survive, or supportive care is deemed more appropriate. Acute peritonitis. Acute inflammation of the peritoneal cavity. May be primary, rare, or secondary, common. Primary peritonitis, typically streptococcal with probable portal focus, of entry via bloodstream rather than intra-abdominal organs actus resu with 4-salinin. Secondary peritonitis, acute perforated appendicitis, acute B. Immediate for antibiotic therapy perforated diverticular disease, upper GI perforation, C. Perforated tumors, perforated ischemic bowel, administration of 4-analgesic pancreatitis, immediate exploratory laparotomy intervention related. Symptoms: anorexia and fever, severe generalized. General principles: the site, signs, fever, tachycardia, generalized abdominal tenderness soon, while ilia. Treatment: resuscitation, established diagnosis, 4 antibiotics. Especially if surgery is likely, metronidazole plus cefuroxime. Treatment: resuscitation, established diagnosis, 4 antibiotics. Especially if surgery is likely, metronidazole plus cefuroxime. Testmanship: valve remains competent despite bowel distension. For less, a 60-year-old male was brought to the ER due to a 2-day history of urgent large bowel obstruction. There is time for a water and off abdominal pain. This was associated with vomiting of fecaloid-soluble enema to try to clear the obstruction and to correct material. On examination you note abdominal distension, hypoactive fluid imbalance. Small bowel obstruction secondary to bowel sounds and generalized tenderness. Patient is diabetic for 20 adhesions should rarely lead to surgery years now and is compliant to medications, and was likewise diagnosed with Crohn's disease. As a matter of urgency, which illness are you trying to rule out first? Key decisions. Is there obstruction of the small or large? Is there an ileus or mechanical obstruction? Is the bowel strangulated? Cardinal features of intestinal obstruction: vomiting, colic, constipation, distension. Common etiologies: adhesions, hernias, ventral, inguinal, femoral, internal neoplasm strictures, radiation, entrythes, intussusception, volvulus, gallstone, ileus, Bezoar, superior mesenteric artery syndrome. Blank. Scan, other diagnostics, water-soluble contrast follow-through, CT, scan, contrast studies. Focus. You requested for an arterial blood gas and electrolyte panel. What is your expected result? Metabolic alkalosis, hyponatremia and hypokalemic. May be primary, rare, or secondary, common. Immediate for antibiotic therapy: perforated diverticular disease, upper GI perforation, C. Administration of for analgesic pancreatitis. General principles: the site, speed of onset, and associations: familial adenomatous polyposis, small bowel tumors, adenocarcinoma of the small bowel, blank. Gist: 10% of small bowel tumors arise from the mesenchymal tissues of the bowel wall and mesentery. Leiomyo, sarc, oma, lipo, sarco, ma. Tumors of myenteric plexus tissues are a variant, GANT, gastrointestinal autonomic nerve tumors. Presence with slow-growing abdominal mass, vague abdominal pain, or occult GI bleeding due to tumor ulceration. Primary lymphoma. 20% of small bowel tumors arise from the lymphoid tissue of the small bowel wall. Almost always non-Hodgkin's, commonest are B-cell lymphomas arising from the mucosa-associated lymphoid tissue, maltomas. Presence with malaise, abdominal pain, diarrhea, or with acute perforation or small bowel obstruction. Diagnosis and investigations. CT scan of the chest and abdomen, angiography, small bowel contrast ileoscopy. Notes: identifies primary tumor, extent of involvement of other tissues, metastatic disease, vascular tumors or GISTs lying close to major visceral vessels, establish resectability for identification of primary tumors, demonstrates proximal lesions presenting with occult, recurrent upper GI bleeding. Medical treatment: chemotherapy, embolization, imatinib. Surgical treatment: surgical resection, for primary lymphoma prior to chemotherapy if there is a high risk of perforation of primary. Surgical resection of metastasis. Primary surgical resection with macroscopic clearance of tumor. For your own reading, a 19-year-old male adolescent was brought to the ER due to a few hours history of vague abdominal pain accompanied by fever, loss of appetite and 2 episodes of loose stools. PE of the abdomen, hyperactive bowel sounds, soft, with direct and rebound tenderness on the RLQ. You are suspecting acute appendicitis and thus called the surgery resident on duty. He, however, shouted at you on the phone, expressed his dismay and hanged up the phone for you didn't even refer the patient first to the obstetrics gynecology resident to rule out ectopic pregnancy. Which is the next appropriate next step? Call the surgery resident back. Refer first to the obstetrics gynecology resident. Do pregnancy test first before referring. Request first for a CBC and urinalysis. Send for right lower quadrant abdominal and pelvic ultrasound. blank. Primarily related to the neck of the diverticulum. Associated with constant and protracted pain in the left iliac fossa, with systemic symptoms and fever, alteration of bowel habit, urinary symptoms, abdominal distension, palpable mass, pelvic tenderness, or mass on rectal exam. Diagnostics: plain abdominal X-ray, air contrast, barium enema, ultrasound, CT scan, flexible sigmoidoscopy. Remarks: do not show any finding. Outpouching, luminal narrowing. Bright ear out of the bowel wall. Outpouchings of colonic wall. Inflammation, stricture, or stenosis. Medical management: mild diverticulitis, broad spectrum antibiotics for 7 days, clear liquids for 2 to 3 days, then bland solid food as symptoms subside. Severe diverticulitis, admitted, NPO for bowel rest, for fluid replacement, NGT if there evidence of significant ileus or bowel obstruction, for antibiotics, pain control. Surgical management: indications for operative management include generalized peritonitis and failure of non-operative therapy in 3 to 5 days. Operative options: percutaneous drainage of diverticular abscess, for confined pericolic or pelvic abscess. Hartmann's procedure, for patients with purulent or fecaloid peritonitis. Resection and primary colorectal reanastomosis, considered only on highly selected situations wherein the sepsis is confined with minimal bowel distension and edema. Transverse colostomy and drainage, no longer used. Testmanship: a 38-year-old male was brought to ER due to a sudden bout of profuse bloody diarrhea associated with urgency, anorexia, abdominal cramps, and subsequent episodes of watery-based stools. He is weak and dry-looking. BP equals 90/60, CR equals 120, RR equals 28, T equals 39.2. C. Abdomen was distended with generalized tenderness. Initial laboratory examination results are shown below. What is the most likely diagnosis? Parameters. Values. Nice to know. Extraintestinal manifestations. Present with active disease: skin, erythema nodosum, pyoderma gangrenosum, mucous membranes, aphthous, ulcers of the mouth and vagina, eyes, iritis, joints, flitting, arthralgias/arthritis present independent of disease activity, joints, sacroiliities, ankylosing spondylitis, hepatobiliary, chronic active hepatitis, cirrhosis, sclerosing cholangitis. Investigations: colonoscopy, double contrast barium enema. Medical therapy: corticosteroids, sulfasalazine and aminosalicylates, immunosuppressive agents, azathioprine, cyclosporin, antidiarrheal agents, diet and nutrition. Therapy of proctitis, 5-ASA suppository, steroid foams, or 5-ASA enemas. Therapy for proctosigmoiditis, steroid foam or 5-ASA enemas, oral prednisolone to induce remission in refractory cases. Therapy of extensive colitis, involvement of proximal colon to splenic flexure requires systemic agents, and disease activity dictates the choice of agent. Mild/moderate disease, sulfasalazine or 5-ASA with or without prednisolone or immunosuppressive agents. Severe colitis, admitted with complete workup, resuscitation, for antibiotics, steroids. Therapy during pregnancy and nursing, aminosalicylate, and 5-ASA compound. Indications of surgical management: perforation, generalized peritonitis, massive colonic hemorrhage, toxic megacolon, deterioration of acute colitis, no improvement in 24-72 HRS of admission, minor improvement in 5 to 7 days of admission. Surgical options: restorative procticolectomy, complete procticolectomy and permanent end ileostomy, colectomy with ileorectal anastomosis. Focus: above-mentioned patient was referred for emergency surgery. Which is the most appropriate choice? Restorative procticolectomy, complete procticolectomy and permanent end ileostomy, colectomy with ileorectal anastomosis, subtotal colectomy and end ileostomy. Chronic inflammatory non-caseating, granulomatous disease affecting any part of the GI tract. Precise etiology is unknown, but products from the bacterial flora combined with a genetic predisposition, family history, are factors. Bimodal distribution: first peak at 20 to 29 years, second small peak at 60 to 80 years. Inflammatory features: fever, malaise, abdominal pain, often right iliac fossa, change in bowel habit, usually diarrhea without blood, and weight loss. Children and adolescents may have failure to thrive or have retarded growth. Rectal bleeding is rare except in Crohn's colitis. Fistulizing features: paraenteric abscess formation often with a tender abdominal mass, fistula formation, ileocolic, ilioileal, iliocutaneous, rarely free perforation with features of peritonitis. Stenosing features: colicky abdominal pain, weight loss due to poor food intake, food fear, palpable or visible distended small bowel loops. Blood exams: barium small bowel series, small bowel enema, colonoscopy and biopsy, abdominal CT scan labeled white cell scan. Features: similar to UC, demonstrate strictures, gross mucosal changes and internal fistulas, demonstrates aphthous ulcers, fissures, and mucosal edema. Full colonic assessment demonstrates internal fistulas, intra-abdominal abscesses and thickening of the bowel wall, demonstrates whether the symptoms are mainly inflammatory or obstructive, and shows microperforations with abscesses. Medical management: no definite treatment. Centered on palliation of symptoms, control of inflammation and correction of nutritional deficiencies. Mild-moderate disease: 5-ASA with metronidazole, with or without prednisolone. Severe disease: active resuscitation, 4 steroids and 4 antibiotics. Maintenance therapy with immunosuppressives, azathioprine, 6-mercaptopurine and anti-TNF-alpha, infliximab, for fistulizing complications. Surgical management. Principle: to deal with septic complications, relieve significant bowel obstruction, and remove as little bowel as possible. Indications: acute, free perforation, severe hemorrhage, acute severe colitis, complete intestinal obstruction. Blank. Growth retardation, blank. Growth retardation, cancer treatment or prevention. Surgical options: conservative resection, strictureplasty. Variable site of involvement: ulcerative colitis. The rectum is always involved. May extend proximally in a continuous fashion. Inflammation and ulceration are limited in the mucosa and submucosa. Crohn's disease. Portion of may involve any portion of the GI tract, particularly the ileocecal region, in a discontinuous pattern, skip lesions. The rectum is often spared. Transmural inflammation is seen. History/PE. Bloody diarrhea, lower abdominal cramps, tenesmus, urgency, exam may reveal orthostatic hypotension, tachycardia, abdominal tenderness, frank blood on rectal exam and extraintestinal manifestations. Crohn's disease. Abdominal pain, abdominal mass, low-grade fever, weight loss, watery diarrhea, exam may reveal fever, abdominal tenderness or mass perianal fissures, fistulas and extraintestinal manifestations. Extraintestinal manifestations. Ulcerative colitis, aphthous stomatitis, episcleritis/uveitis, arthritis, primary sclerosing cholangitis, erythema nodosum, pyoderma gangrenosum. Crohn's disease. Same as ulcerative colitis as well as gallstone, nephrolithiasis and fistulas to the skin, bladder, or between bowel loops. Diagnosis. Ulcerative colitis. CBC, AXR, stool cultures, ONP, stool assay for C. difficile, colonoscopy can show diffuse and continuous rectal involvement, friability, edema, and pseudopolyps. Definitive diagnosis can be made with biopsy. Crohn's disease. The same lab workup as UC. Upper GI series with small bowel follow-through. Colonoscopy may show aphthoid, linear, or stellate ulcers, strictures, cobblestoning, and skip lesions. Creeping fat may also be present during laparotomy. Definitive diagnosis can be made with biopsy. Treatment. Ulcerative colitis. 5-ASA, e.g. sulfasalazine, mesalamine, topical or oral corticosteroids and immunomodulating agents, e.g. azathioprine, for refractory disease. Total procticolectomy is curative for long. Risk of colorectal cancer, standing or fulminant colitis or toxic megacolon, it also decrease cancer risk. Crohn's disease. 5-ASA, corticosteroids and immunomodulating agents, e.g. azathioprine, infliximab, are indicated if no improvement is seen. Surgical resection may be necessary for suspected perforation, stricture, fistula, or abscess. May recur anywhere in the GI tract. Incidence of cancer. Ulcerative colitis. Standing risk of colorectal cancer in risk of colorectal cancer in long-standing cases. Monitor with frequent fecal occult blood screening and yearly colonoscopy with multiple biopsies after 8 years of disease. Crohn's disease. Malignancy is lower than incidence of secondary. Malignancy is lower than ulcerative colitis, but greater than the general population. A 74-year-old female goes to surgery for episodes of alternating watery stools and constipation. Which initial investigation is most appropriate? Barium meal and follow-through. Barium enema. Sigmoidoscopy. CT scan of the abdomen. A patient and GT 65 years old with a history of altered bowel habit needs first to have a large bowel cancer excluded. Sigmoidoscopy is the optimum first investigation to diagnose carcinoma of the rectum and lower sigmoid. Barium enema is neither as sensitive nor as specific as endoscopy. Small tumors can easily be missed by overlapping bowel shadows. Barium meal and follow-through is an investigation used for disorders of gastric and small bowel motility. Abdominal CT scan is more helpful for imaging solid viscera than for picking up bowel pathology, but may be useful for imaging liver metastases after the primary diagnosis is made. Unspecified currency. Blank. Nice to know. There is a very strong association between adenomatous polyps, villus adenoma, and colorectal cancer. These polyps usually present as an occult/overt bleed with microcytic type of anemia. Other manifestations are nonspecific. Endoscopy remains as the most sensitive method for detection and permits therapeutic intervention, polypectomy with biopsy, cautery. Surgical resection of a colorectal polyp may be required, especially if the polyp is larger than 2 to 3 cm and is sessile, as villus adenomas often are. Morphology: polypoid, ulcerating, stenosing or infiltrative tumor mass. Left side of the colon and rectum 75%. Rectum -45%. Descending/sigmoid -30%. Transverse -5%. Right-sided -20%. 3 to 5% have a synchronous carcinoma at time of diagnosis. Rectal location: PR bleeding, deep red on the surface of stools. Change in bowel habit, difficulty with defecation, sensation of incomplete evacuation, and painful defecation, tenesmus. Descending and sigmoid location: PR bleeding, typically dark red, mixed with stool, sometimes clotted. Change in bowel habit, typically increased frequency, variable consistency, mucus PR, bloating, and flatulence. Right-sided location: iron deficiency anemia may be the only elective presentation. ER presentations: up to 40% of colorectal carcinomas will present as emergencies. Large bowel obstruction. Perforation with peritonitis. Acute PR bleeding. Diagnosis: screening FOBT. PR examination or rigid sigmoidoscopy. Flexible sigmoidoscopy. Colonoscopy. Barium enema. Tumor marker, CEA. Staging: CT scan, MRI, ultrasound, X-ray, colonoscopy. Surgical treatment: carcinoma of cecum or ascending colon, right hemicolectomy. Carcinoma of the transverse colon, right hemicolectomy, extended right hemicolectomy, subtotal colectomy. Carcinoma of the descending colon, left hemicolectomy. Carcinoma of the sigmoid colon, high anterior resection or limited sigmoid colectomy. Anorectal carcinoma, abdominoperineal resection. Carcinoma or the lower rectum, lower anterior resection. Adjuvant therapy. Chemoradiation. Treatment of metastases. Liver. Resection, hepatic artery embolization or ligation, chemotherapy, cryosurgery or radiofrequency ablation. Small bowel. Resection, bypass. Pelvis. Radiotherapy, 35 to 55 CGY, systemic chemotherapy, e.g. monoclonal antibody. Must know. Risk stratification, updated. Who is at risk? Category 1, average or slightly increased risk, and LT 1% 10-year risk of CRC, asymptomatic people with, no personal history of bowel cancer, colorectal adenomas, inflammatory bowel disease, or family history of CRC, or *1 first or 1 first and second degree relative with CRC diagnosed at age 55 years or older. What should be done? IFOBT low dose ASA, 100 to 300 mg daily, should be actively considered to prevent CRC. Blank. Category 2, moderately increased risk, 1-4% 10-year risk of CRC, asymptomatic people with *1 first-degree relative with CRC diagnosed before age 55 years, or *2 first-degree relatives with colorectal cancer diagnosed at any age *1 first-degree relative and at least 2 second-degree relatives diagnosed with colorectal cancer at any age. IFOBT colonoscopy low-dose ASA, 100 to 300 mg daily, should be actively considered. Blank. Category 3, high risk, RR of 4-20, asymptomatic people with * at least 3 first or second degree relatives with CRC, with at least one relative diagnosed aged and LT 55 years * at least 3 first-degree relatives with CRC diagnosed at any age. Refer to Familial Cancer Clinic for IFOBT every 2 years from 35 to 44 years of age, colonoscopy every 5 years from 45 to 74 years of age. People with high-risk familial syndromes, *3 or more first-degree or second-degree relatives on the same side of the family diagnosed with CRC or other Lynch syndrome-related cancers, *2 or more first or second-degree relatives on the same side of the family diagnosed with CRC, including any of the following high-risk features: multiple CRC in one person, CRC before age 50 years. For high-risk familial syndromes, refer to Familial Cancer Clinic for genetic risk assessment and genetic screening of affected relatives. Refer to bowel cancer specialist to plan appropriate surveillance and dose of ASA. Frequency and starting age of colonoscopic surveillance will be determined by specialist team. Starting age and dose of ASA will be determined by specialist team. A family member who has or had Lynch syndrome-related cancer. For familial polyposis syndromes, refer to Familial Cancer Clinic for genetic risk assessment and genetic screening of blank. Frequency and starting age of colonic surveillance and chemoprevention will be determined by specialist team. People with familial polyposis syndromes, blank. Diagnosis and investigations. Rigid sigmoidoscopy may show features of mucosal inflammation, particularly the anterior rectal mucosa. Prolapse may be demonstrable on straining in clinic. Defecating proctogram may be performed to confirm the diagnosis if it is unclear and surgery is contemplated. Colonic transit studies may be used if there is suspected slow transit constipation and resection is possible. Medical treatment: avoidance of straining and adaptation of defecatory habit, biofeedback. Avoidance of constipation, stool softeners and bulking agents rather than stimulants. Surgical treatment: mucosal prolapse, recurrent banding or dilute phenol injection of excess mucosa, mucosal excision, stapled anopexy also called procedure for prolapse and hemorrhoids, PPH. Full-thickness prolapse, internal or external surgery indicated for failure to control symptoms, choice of operation depends on age and extent of prolapse. Delorme's perineal rectopexy, mucosal excision with sutured plication of the excessively long rectal muscle tube in an effort to shorten it to prevent prolapse, is ideal for very frail and elderly but least successful with highest recurrence rate of all surgical procedures. Altmaier's perineal rectal resection, mucosal and rectal muscle tube excision with sutured perineal anastomosis, avoids abdominal operation but has increased morbidity due to perineal anastomosis. Transabdominal rectopexy, mobilization of the rectum and suturing to the presacral fascia, may be done via laparotomy or laparoscopically. Most surgeons no longer use a prosthetic mesh as it is associated with complications. Highest success rate for prevention of recurrence of prolapse. May be combined with a sigmoid resection if there is marked associated constipation on transit studies. A 56-year-old female seeks consult for on and off painless bleeding dripping into the pen after defecating. She also notes a palpable, reducible mass on the anal area every time she defecates. She has no other comorbidity and has been living happily with her 9 children. What illness are you considering? The masses of spongy vascular tissue est hadlinst henisere located at 3, 6, and 9 o'clock. Positions. Effects of gravity, increased anal tone, and the effects of straining make them bulky and loose, and so to protrude to form piles. While congestion from a pelvic tumor, major factor contributing to this illness is straining. While congestion from a pelvic tumor, pregnancy, or portal hypertension are important in only a minority of cases. May be external, internal, or mixed. Diagnosis: abdominal exam to rule out other diseases, rectal exam to check for piles, proctoscopy to see internal hemorrhoids, or sigmoidoscopy to identify rectal pathology higher up. Classification of hemorrhoids. 1. Degree. Remain in the rectum. 2n. Degree. Prolapse through the anus. On defecation but spontaneously reduce. 3r. Degree. As for second degree but require digital reduction. 4t. Degree. Remain persistently prolapsed. Treatment. Best treatment is hemorrhoid crea. Infrared coagulation, applied for 1.5 to 2s, 3-8x to localized areas of piles works by coagulating vessels, and tethering mucosa to subcutaneous tissue. Sclerosance, 2 ml of 5% phenol in oil is injected into the pile above the dentate line, risk for impotence, prostatitis. Rubber band ligation, and LT3 band treatments per session, risk of bleeding and infection. Cryotherapy, freezing but may produce a lot of watery discharge after the procedure. Hemorrhoidectomy, 4 H. Dregery piles, excision of piles with or without ligation of pedicles, risk of hemorrhage or stenosis. Miscellaneous topics. Anal fissure. What is it? Linear tear or superficial ulcer of the anal canal extending just below the dentate line to the anal margin, frequently in the midline posteriorly or anteriorly in females after pregnancy. Exact etiology is unknown but is associated with constipation and trauma. Severe anal pain during and just after defecation associated with anal outlet bleeding. What is the most important step in its diagnosis? How is it treated? High fiber diet, topical anesthetic, ointment, glycerin trinitrate paste, chemical sphincterotomy. Eusigmoid, volvulus. What is it? Occurs when the bowel twists on its mesentery, which can produce severe, rapid, strangulated obstruction, more common in the elderly, constipated, and comorbid patient. How is it diagnosed? AXR, inverted U-loop bowel, or coffee bean shape. How is it treated? Sigmoidoscopy with flatus tube insertion, sigmoid colectomy. Eupilonidal, sinus. What is it? Obstruction of natal cleft hair follicle 6 cm above the anus, with ingrowing of hair, excites a foreign body reaction, and may cause devious secondary tracts which open laterally with or without abscesses, with foul-smelling discharge. How is it diagnosed? Inspection. How is it treated? Excision of the sinus tract with or without primary closure. Pre-op antibiotics with cefuroxime plus metronidazole. Complex tracts can be laid open and packed individually, or skin flaps can be used to cover the defect. A postoperative. Adhesions. What is it? Fibrous bands intra-abdominally that form secondary to operative handling of intra-abdominal and pelvic organs. Other predisposing factors include infection, radiation injury, and inflammatory processes like Crohn's disease. Usually presents as bowel obstruction. How is it diagnosed? High index of suspicion, laparoscopy/laparotomy. How is it treated? Avoid operating as much as possible, do laparoscopy if possible, adhesiolysis if surgically warranted. Uzenkers. Diverticulum. What is it? A pulsion diverticulum of the hypopharynx mostly occurring in the elderly. It involves herniation of the esophageal mucosa posteriorly between the cricopharyngeus muscle and the inferior pharyngeal constrictor muscle. Hypothetical abnormalities. Abnormal timing of deglutition resulting in closure of the CP muscle when ideally it should be opening. Incomplete CP muscle relaxation, elevated resting tone of the entire upper esophageal sphincter. Loss of CP muscle elasticity. CP muscle myopathy or denervation atrophy. CNS injury with a focal spastic CP muscle. CP muscle spasm in response to GORD. Presence with dysphagia, 98%, regurgitation, sensation of food sticking to the throat, special maneuvers to dislodge food, coughing after eating, aspiration of organic material, unexplained weight loss, Vater X or borborygmi in the neck. How is it diagnosed? Barium swallow with video fluoroscopy, criterion standard for confirmation. Endoscopy, FEES, flexible/rigid esophagoscopy. How is it treated? Non-operative if and LT1-CM, may give botulinum toxin. CP myotomy, diverticulectomy with CP myotomy, endoscopic diverticulotomy with stapler. Uretrosil. What is it? Herniation or bulging of the posterior vaginal wall, with the anterior wall of the rectum in direct apposition to the vaginal epithelium. A defect of the rectovaginal septum, not the rectum. Consequence of attaining an erect bipedal posture. Mostly caused by childbirth and chronic increases in intra-abdominal pressure. How is it diagnosed? Signs and symptoms are the most important. Ancillaries, urodynamic and anorectal physiologic testing, barium enema, colonoscopy, colonic transit study, pelvic floor fluoroscopy, dynamic MRI. How is it treated? If asymptomatic, expectant management, pelvic floor exercises, pessaries. Surgery, posterior colporrhaphy, defect-directed repair, posterior facial replacement, transanal repair, some abdominal approaches. Urectus, sheath hematoma. What is it? Result of bleeding into the rectus sheath from damage to the superior or inferior epigastric arteries or their branches or from a direct tear of the rectus muscle. Immediate cause of rupture may be external trauma from surgery, or excessively vigorous contractions of the rectus muscle. How is it diagnosed? Laboratory examinations include FBC, coagulation studies, ABG. Ultrasound as first line, alternatives are CT scan or MRI. How is it treated? Conservative if hemodynamically stable but may do embolization as an alternative to surgery. Surgery, evacuation, ligation, and repair. Blank. More common in female, can be made of cholesterol, more common in females and incidence increases with age. Can be made of cholesterol, pigment, or mixed. You examine a 45-year-old female for complaints of on and off epigastric pain and bloatedness aggravated by eating fresh salads. She was diagnosed with acid peptic disease some few years back and has been on medications ever since. Endoscopy was likewise performed and showed minor gastritis. You are utterly not convinced that this is entirely APD. What is the next appropriate step? Diagnosis can be easily achieved by ultrasound, bright echo, white, with acoustic shadowing, dark area, radiating to the stone. If with cholecystitis, findings of gallstones with thickening of the gallbladder wall, and GT4MM, with occasionally a decrease in density adjacent to the gallbladder wall suggesting a halo effect. Other investigations: oral cholecystography, coloscintigraphy, endoscopic retrograde cholangiopancreatography, hematology and biochemistry. Clinical situations. Operative treatment may either be through open cholecystectomy or laparoscopic cholecystectomy, with or without intraoperative cholangiogram. Post-operative pain may be due to common bile duct injury, retained stone, sphincter of Oddi dysfunction, or neuralgia secondary to segmental nerve injury. Many, in whom no cause for further pain can be identified, have been labeled as having post-cholecystectomy syndrome. This condition does not exist and represents those patients who did require a cholecystectomy in the first place. I.e., their pain was not due to the gallstone and therefore the gallbladder removal has not influenced their symptomatology. Focus: a 58-year-old female was brought to the ER due to a RUQ pain, yellowish discoloration of the skin and sclera, and high-grade fever and chills. She had recurrent epigastric pain in the previous 6 months but has never sought medical consult. What is the most likely diagnosis? Blank. Focus: the above-mentioned patient underwent emergency RUQ ultrasound which showed dilated common bile ducts with multiple gallbladder and hepatic abscesses. What is the appropriate next step? Perform an emergency abdominal CT scan. Start supportive measures and antibiotics, then observe for clinical improvement. Refer for ERCP with endoscopic sphincterotomy. Refer to surgery for laparotomy. Infected in most cases. Non-suppurative acute cholangitis is most common and may respond relatively rapidly to supportive measures and to antibiotics. In suppurative acute cholangitis, endoscopic or surgical intervention is required on top of supportive measures and antibiotics. A 40-year-old male was brought to surgery due to chronic cough, pleuritic chest pain and occasional dyspnoea. Pertinent physical examination findings include decreased breath sound on the right lower lung, vague abdominal tenderness and jaundice. You also note generalized erythematous, pruritic wheals which according to the patient only appeared yesterday after a sudden bout of severe abdominal pain. What is the most likely diagnosis? Parasitic infection of a flatworm under the genus Echinococcus, E. granulosus equals CE, E. multicularis equals AE, E. vogeli. It is endemic in Australia. The two most commonly involved organs, liver and lung. Signs/symptoms range from nonspecific pain, cough, low-grade fever, sensation of abdominal fullness to obstructive jaundice, abdominal pain/biliary colic, urticaria/anaphylaxis, cholangitis, hydatidemia/enteric, hepatosplenomegaly, HBT, chronic cough, dyspnoea, pleuritic chest pain, hemoptysis, lungs, headache, dizziness, decreased level of consciousness, specific neurologic deficits, brain, bone and muscle tenderness, palpable mass, extremities, decreased visual acuity, blindness. Exophthalmos, eyes. Diagnostics laboratory studies. Findings: elevated bilirubin and ALP, leukocytosis, eosinophilia, hypogammaglobulinemia, positive screening with indirect hemagglutination test and ELISA, positive confirmatory tests with immunodiffusion and immunoelectrophoresis. Imaging studies. Pain films, thin rim calcification delineating a cyst. Ultrasound, demonstration of the daughter cysts and hydatid sand. CT scan, 98% accuracy, best test to differentiate hydatid cyst from amoebic and pyogenic cysts. MRI, same as CT. Procedures. ERCP, both diagnostic and therapeutic in patients with intrabiliary rupture of a hydatid cyst, in whom sphincterotomy can be performed. Medical treatment. CE. Indications: primary liver or lung cysts that are inoperable, because of location and medical condition, patients with cysts in 2 or more organs, and peritoneal cysts. Contraindications: early pregnancy, bone marrow suppression, chronic hepatic disease, large cysts with the risk of rupture, and inactive or calcified cysts. Indications: perioperative. Choice of medications: albendazole or mebendazole AE. Indications: perioperatively with benzimidazoles with radical resection is feasible to eliminate residuals, in patients who underwent partial resection, inoperable, or those with liver transplant, long-term chemotherapy. Contraindications: early pregnancy, severe leukopenia. Surgical treatment. CE. Indications: large liver cysts with multiple daughter cysts, superficially located single liver cysts that may rupture, traumatically or spontaneously, liver cysts with biliary tree communication or pressure effects on vital organs or structures, infected cysts, cysts in lungs, brain, kidneys, eyes, bones, and all other organs. Contraindications: general contraindications, multiple cysts in multiple organs, cysts that are difficult to access, calcified cysts, very small cysts. Choice of surgical technique: radical surgery, total paracystectomy or partial affected resection, if possible, conservative surgery, open cystectomy, simple tube drainage of infected and communicating cysts AE. Indications: resectability of the liver lesion. Note: other interventions include dilatation, stenting, drainage of collections, and sclerosis of esophageal varices. Contraindications: inoperable lesions, extensive lesions, and lesions extending outside the liver and involving other organs. Choice of surgical technique: radical surgery, with complete excision of the lesion, partial or total hepatectomy. Testmanship. A 47-year-old male was brought to ER due to sudden onset of severe epigastric pain and vomiting. He claims to have had a history of hyperacidity and that this was aggravated by a drinking spree last night, consuming 8-10 SD of regular beer. No other comorbidity or pertinent findings in the past medical history. You note him to be more comfortable as he leans forward. BP equals 80/60 CR equals 125 RR equals 26 T equals 38. Acute pain. See, there is direct tenderness over the epigastric area. What are your differentials? Acute pancreatitis. Causes include G. gallstone, E. ethano, T. traum, S. steroid, M. mump, A. autoimmune disease, S. scorpion stin, H. hypercalcemia/hypertriglyceridemia, EIC. D. drug. Symptoms/signs: gradual or sudden severe epigastric or central abdominal pain, radiating to the back, prominent vomiting, tachycardia, fever, jaundice, shock, ileus, rigid abdomen with or without local/generalized tenderness and peri-umbilical discoloration, Cullen's sign, or in the flanks, Gray Turner's sign. Focus. Which initial blood examination would most likely confirm your diagnosis? Serum amylase, serum lipase. Abdominal CT, upper abdominal ultrasound. Diagnostic examinations include amylase, lipase, ABG, AXR nopsoas shadow, increased retroperitoneal fluid, sentinel loop of proximal jejunum, solitary air-filled dilatation, erect CXR, CT scan, MRI, US, ERCP. Focus. What is your first step in the management of this patient? Insert in 4-line and give lots of normal saline, then observe. Immediately give pethidine or morphine. Refer for immediate ERCP. Call surgery for immediate laparotomy and debridement. Management steps. Set up 4-line and hydrate with NSS to counter 3. Space sequestration until vital signs are satisfactory and urine flows to normal volume. Insert a urinary catheter and consider CVP monitoring. Analgesia. Hourly VS, strict IO, daily FBC, BUN/CREA, electrolytes, Ca. In suspected abscess formation or pancreatic necrosis, on contrast-enhanced CT, consider parenteral nutrition with or without laparotomy and debridement. Antibiotics for severe disease. ERCP plus gallstone removal may be needed if there is progressive jaundice. Repeat imaging to monitor progress. Early complications, shock, ARDS, renal failure, DIC, sepsis, hypocalcemia, hyperglycemia. Late complications, and GT1WK pancreatic necrosis and pseudocyst, fluid in lesser sac, abscess, bleeding, thrombosis, fistulae, recurrent edematous pancreatitis. Modified Glasgow criteria for predicting severity of pancreatitis. AO. P. Age, neutrophils, calcium, renal function, enzymes, albumin, sugar. And LT8-KPa and GT55 years, WBC and GT15x10. /L and LT2 mol/L urea and GT16 mol/L LDH and GT600 IU/L, AST and GT200 IU/L and LT32G/L, serum, blood glucose and GT10 mol/L. Which of the following is an incorrect statement about pancreatic carcinoma? Most pancreatic cancers are incurable. Palliation can be achieved with a biliary stent. Palliation can be achieved by surgical bypass of the tumor. Ampullary cancer has a worse prognosis than carcinoma of the body of the pancreas. Survival rate of 5% at 5 years from diagnosis can be expected. One of the highest fatality rate, 5-year survival rate of 5%. Risk factors include age more than 50 years, most important risk factor, cigarette smoking, hereditary pancreatitis, intraductal papillary neoplasms, most commonly affecting the main duct, and chronic pancreatitis. Most will present with painless jaundice if the tumor is in the pancreatic head. Pancreatic or biliary malignancy should be the leading differential diagnosis in patients older than 50 who present with this symptom: anorexia, weight loss, new or worsening glucose intolerance, pain at the back, only if the tumor arises in the body and tail and affects the celiac ganglia, and acute pancreatitis. Examination most commonly discloses weight loss and jaundice, and rarely, Trousseau syndrome, migratory thrombophlebitis, or Courvoisier sign, palpable gallbladder due to compression of the distal bile duct. Most common sites of metastasis include the liver, through the portal vein, lungs, and peritoneum. Focus, if the lesion is less than 2 cm, which investigation permits a more sensitive analysis of the tumor. Contrast-enhanced multiplanar CT scan. Endoscopic ultrasound. Magnetic resonance imaging. Abdominal X-ray. Endoscopic retrograde pancreatography. CT scan is 90% sensitive, but lesions less than 2 cm in diameter often cannot be visualized. EUS permits more sensitive analysis of tumors less than 2 cm and can facilitate tissue sampling by fine needle aspiration if the diagnosis is in question. In patients who have imaging that is characteristic of resectable pancreatic cancer, tissue sampling prior to potential curative resection is not required. Staging, treatment, and prognosis of pancreatic adenocarcinoma. Stage. Localized. Findings. No vascular involvement of the celiac axis or SMA, no extrapancreatic metastases. Treatment. Surgical resection combined with neoadjuvant or adjuvant chemoradiotherapy. Prognosis. 20% survival at 5 years. Stage. Advanced. Locally. Findings. Vascular. Invasion of the celiac axis or SMA, occlusion of the portal/SMV, no extrapancreatic metastases. Treatment. Neoadjuvant. Chemoradiotherapy, with restaging thereafter. Prognosis. 10 months. Stage. Metastatic. Findings. Extrapancreatic metastases. Treatment. Palliative chemotherapy. Prognosis. 6 months. Primary hepatocellular carcinoma may be caused by all of the following except alcohol, hemochromatosis, hepatitis virus, steroids, gallstones. Third leading cause of cancer-related death worldwide. Major risk factors are male sex, chronic hepatitis B and C infection, hemochromatosis and alpha-1 antitrypsin deficiency, and cirrhosis from any cause. Ultrasound is the most widely available and least expensive imaging, but CT and MRI offer better resolution. For patients with normal imaging at diagnosis, the recommended interval for surveillance imaging at diagnosis is 6 months. Serum alpha-fetoprotein measurement does not have sufficient diagnostic accuracy alone to be a valuable tool for early detection. HCC lesions greater than 2 cm in diameter can be accurately diagnosed in patients with cirrhosis using contrast-enhanced CT, MRI, and angiography. Arterial hypervascularization with delayed venous contrast washout on at least 2 imaging studies. When only a single imaging study documents these features, HCC can still be diagnosed if the serum AFP level is 400 ng/ml or greater. Image-guided biopsy is reserved for patients in whom radiologic criteria are equivocal or inconsistent with HCC. Liver transplantation is the most effective therapy for early disease. Surgical resection is reserved for patients without advanced fibrosis or portal hypertension whose tumor location is amenable to operative therapy. Ablative treatments, including transarterial hepatic artery chemoembolization, radiofrequency ablation, and percutaneous alcohol injection, can prolong short-term survival in selected patients and are commonly used as a bridge to liver transplantation. For patients with advanced HCC and intact liver function, the use of sorafenib has been shown to improve survival as compared with standard therapy. Miscellaneous topics. Gallbladder cancer. What is it? Most common cancer of the biliary tree. Risk factors include age greater than 50 years, female sex, gallstones, obesity, gallbladder polyps larger than 1 cm, chronic infection with Salmonella typhi, and porcelain gallbladder. Prophylactic cholecystectomy should be considered in patients with gallbladder polyps larger than 1 cm, gallstones larger than 3 cm, or porcelain gallbladder. Symptoms are nonspecific: abdominal discomfort, nausea, anorexia, weight loss. How is it diagnosed? Laboratory findings are often normal until obstructive jaundice develops. Often diagnosed intraoperatively or on abdominal imaging. How is it managed? Depends on the stage. Open cholecystectomy if cancer is localized to the gallbladder mucosa. Radical cholecystectomy may be curative in patients with advanced disease but limited extension into adjacent organs. In advanced tumors, curative therapy is not possible and palliative management consists of operative diversion of bile flow or endoscopic stenting of the bile ducts. Use of chemotherapy and radiation for gallbladder cancer has not been definitely demonstrated. Cholangiocarcinoma. What is it? Derived from the biliary tree exclusive of the gallbladder or the ampulla. Risk factors are primary sclerosing cholangitis, biliary atresia, chronic infection with liver flukes, and biliary cysts. No evidence of screening with serial abdominal imaging with or without serum markers, rather, simply high index of suspicion in patients with primary sclerosing cholangitis who develop signs of clinical decompensation. Classified as intrahepatic and hilar/extrahepatic. Intrahepatic cholangiocarcinoma is typically asymptomatic until the tumor is advanced, at which time right upper quadrant discomfort, weight loss, and fever may be the only symptoms. ALP may be elevated. Advanced stage has a poor prognosis and curative resection is not commonly possible, while radiation and chemotherapy are of undefined benefit. Cholangiocarcinoma of the hilum, clat skin tumor, or distal bile duct commonly presents with jaundice caused by complete obstruction of the biliary tree. Suspected when abdominal imaging demonstrates bile duct dilatation and an obstructing lesion. How is it diagnosed? Endoscopic cholangiography with brushings or biopsies of the involved lesion is the best test to diagnose malignant changes of the bile duct. MRCP. How is it managed? MRCP, serum CA19-9, CEA are useful adjuncts. How is it managed? For extrahepatic tumors, operative resection would be required for potential curative management. Hilar cholangiocarcinoma can be resected if the tumor does not extend into both intrahepatic bile ducts. Input 4, Diarrhea Overview. A 55-year-old woman is evaluated for a one-day history of diarrhea. She has had 4 liquid stools in the past 24 hours without visible mucus or blood. The patient does not have fever, nausea, vomiting, abdominal pain, or cramping. She returned yesterday from a 2-week trip to Guatemala, where she traveled to rural areas, swam in a local river, and brushed her teeth with tap water. On physical examination, she is thin and on no acute distress. Vital signs, including temperature, are normal. She has no rash. Her mucous membranes are moist. Bowel sounds are mildly hyperactive, but no focal abdominal tenderness or peritoneal signs are present. Rectal examination reveals no tenderness with heme-negative brown stool in the vault. Which of the following stool studies should be done next? Bacterial culture, viral culture, microscopy for ova and parasites, testing for fecal leukocytes. No diagnostic test is indicated. Characterization. Increase in frequency or liquidity of stool or as stool weight greater than 200 g/d. May be classified by duration. Acute, up to 14 day. Subacute, and GT 14 days, 2 to 4 weeks. Chronic, and GT 30 day. May be classified by specific features. Osmotic, often have stool volumes of less than 1 L/day and have cessation of stooling when they are fasting. Secretory, may pass liters of stool daily, causing severe dehydration and electrolyte disturbances, with persistent stooling despite fasting. A stool osmotic gap can be used to distinguish between secretory and osmotic diarrhea. 292 x stool sodium x stool potassium and LT50 mosm/kg is likely secretory and GT 100 mosm/kg is likely osmotic. Inflammatory, often but not always characterized by blood or mucus in the stool. Malabsorptive, loss of fat, carbohydrates, or protein in the stool secondary to an underlying disease. Evaluation and management. Acute diarrhea is most commonly caused by infectious pathogens and is often self-limited. Evaluation is necessary with certain clinical and demographic indications. Clinical and demographic indications for the evaluation of acute diarrhea. Bloody stools. Fever superscript 338.50 C. Significant abdominal pain. Severe diarrhea leading to volume depletion. Inflammatory bowel disease. Recent antibiotic use. Elderly patients. Hospitalized patients. Pregnant women. Immunocompromised patients. Food handlers. History is of paramount importance and the key clinical features should include travel, medications, surgical history, family history, types of foods regularly ingested, stool timing and characterization, and the presence of associated features such as weight loss, joint pains, skin lesions, or fevers. Evaluation of chronic diarrhea is stepwise and often involves a combination of stool studies, cultures, fecal fat quantification, endoscopic evaluation, upper endoscopy with small bowel biopsies and cultures, colonoscopy with terminal ileal examination and random biopsies, and radiographic images of the pancreas and small bowel. Anytime a patient is referred for an endoscopic evaluation for diarrhea, biopsies should be obtained from the duodenum and colon, even if they appear endoscopically normal, to evaluate for conditions such as celiac disease and microscopic colitis, respectively. Breath testing for sugars or testing for secretagogues are indicate only if the clinical features suggests it so. Nice. To know disorder. Diagnosis, clues or risk factors. Inflammatory bowel disease. Ulcerative colitis. Colonoscopy with biopsies. Bloody diarrhea. Crohn's disease. Ileocolonoscopy with biopsies, small bowel imaging, SBFT, CTE, MRE. Weight loss, microscopic colitis. Colonoscopy with biopsies. Secretory diarrhea. Coeliac disease. Serologies, TTG-IgA, upper endoscopy with small bowel biopsies. Extraintestinal features, family history. Small intestinal bacterial overgrowth. Upper endoscopy with small bowel cultures, hydrogen breath testing. Bloating, excess flatus, malabsorption. Carbohydrate malabsorption. Detailed history, hydrogen breath testing, stool osmotic gap, avoidance trial. Bloating, excess flatus. Pancreatic insufficiency. Features of chronic pancreatitis on imaging, CT, EUS, MRCP, 48 to 72 hour fecal fat quantitation, pancreatic function tests. Known pancreatic disease/resection, weight loss, bile acid malabsorption. Compatible history, clinical response to cholestyramine. Terminal ileal resection, and LT100-CM, bile acid deficiency. Compatible history, steatorrhea, response to medium-chain triglyceride diet, terminal ileal resection, and GT100-CM, ischemia. Colonoscopy with biopsies, for colonic ischemia, duplex ultrasound, or MRA, for chronic mesenteric ischemia. Low-flow states, cardiovascular risk factors, radiation enteropathy/proctopathy. Compatible history, small bowel imaging, colonoscopy with biopsies. Any previous radiation to abdomen or pelvis. Irritable bowel syndrome. Compatible history, fulfills Rome criteria, exclude other diseases. Symptoms relieved after bowel movement. Eosinophilic enterithes. Eosinophilia on small bowel biopsies, for mucosal-based disease, or full-thickness bowel biopsy, for submucosal or serosal-based disease. Atopic history, peripheral eosinophilia, not required. Whipple disease. Small bowel biopsies showing PA plus macrophages that are acid-fast negative, polymerase chain reaction on any biopsied affected tissue. Arthralgia, lymphadenopathy, iatrogenic. Detailed history and review of chart. New medications, initiation of enteral nutrition. Factitious diarrhea. Diagnosis of exclusion. Often high volume and frequency, bulimia, anorexia, weight loss, stool osmolality and osmolar gaps may be helpful, and GT50 mosm/kg, stool magnesium and GT90 milliequivalent/L may be diagnostic. Testmanship. A 42-year-old woman is evaluated for an 8-month history of crampy abdominal pain and 3 loose bowel movements per day. The pain is relieved by a bowel movement. There are no nocturnal bowel movements, and there is no blood or dark tarry material in the stool. She has not had fever, night sweats, or weight loss. She has a history of Hashimoto's disease and is treated with levothyroxine. On physical examination, temperature is 36.8. C. Blood pressure is 128/84 m. A 40. C. Blood pressure is 128/84 mmHg, pulse rate is 64/min, and respiratory rate is 16/min, BMI is 23. No rash is noted. There is mild diffuse abdominal tenderness without peritoneal signs and no abdominal masses. Rectal examination is normal. Complete blood count and thyroid stimulating hormone level are normal. Which of the following is the most appropriate next step in management? Breath test for bacterial growth. Colonoscopy with random biopsies. Stool culture. Tissue transglutaminase testing. Immunologic response to dietary gliadins in patients who are genetically at risk. Typical features include diarrhea, bloating, and weight loss, but extraintestinal manifestations are also seen. Best serologic test is tissue transglutaminase, TTG, IgA antibody. Any patient with a positive serologic test or clinical features of coeliac disease despite negative serologic tests should undergo small bowel biopsies. Testing for HL status, DQ2 or DQ8, is not routine but considered in patients with non-diagnostic histology or negative serologic markers, and in patients who are following a gluten-free diet before diagnosis and who refuse to reintroduce gluten to undergo testing. What is the treatment of choice? Adhere to a gluten-free diet, oat, wheat, barley, rye. Focus. What would you consider for a patient whose symptoms are recurrent or do not respond to a gluten-free diet? Associated conditions that may account. What would you consider for a patient whose symptoms are recurrent or do not respond to a gluten-free diet? Steroids, immunosuppressive drugs, chemotherapy. Associated conditions that may account for recurrent diarrhea are microscopic colitis, 70-fold increased risk, lactose malabsorption, small intestinal bacterial overgrowth, pancreatic insufficiency, inflammatory bowel distress, refractory coeliac disease, or enteropathy-associated T-cell lymphoma. Associated disorders include Down syndrome, type 1 diabetes mellitus, juvenile rheumatoid arthritis, thyroid disease, and autoimmune liver conditions. Baseline investigations include bone densitometry, evaluation of vitamin and mineral levels, and vaccination against encapsulated organisms. Miscellaneous topics. Intestinal, small. Intestinal bacterial overgrowth. What is it? Organism/ml, an alteration in type, resembling colonic flora, of bacteria cultured from the small intestine. Risk factors include dysmotility, scleroderma, intestinal pseudoobstruction, autonomic neuropathy, amyloidosis, systemic myopathies, altered gastric acid, achlorhydria, gastric resection, pharmacologic acid suppression, structural, small bowel strictures, small bowel diverticula, enterocolonic fistula, radiation enteropathy, altered anatomy, resected ileocecal valve, blind loops, afferent limbs, any. Intestinal bypass, short bowel syndrome, advancing age, immunodeficiency, coeliac disease, pancreatic insufficiency, cirrhosis. Clinical features include diarrhea, bloating, weight loss, nutritional deficiencies, macrocytosis from B12 deficiency. How is it diagnosed? Hydrogen breath testing showing an early peak of hydrogen production due to fermentation of the carbohydrate by small intestinal bacteria. Upper endoscopy with small bowel cultures that disclose greater than 10 organism/ml of aerobes and anaerobes. How is it managed? Single course of antibiotic or rotating antibiotics that may include amoxicillin clavulinate, fluoroquinolones, tetracycline derivatives, metronidazole, or rifaximin. Lactose avoidance. A short bowel syndrome. What is it? Presence of less than 200 centimeters of remaining small bowel, normal is 600 centimeters, and usually follows massive resection of intestine. Most common causes of short bowel syndrome in adults are Crohn's disease, ischemia, volvulus, trauma, and certain tumors, desmoids. Over time, the colon can compensate by absorbing increasing amounts of water and electrolytes, and calories from carbohydrate malabsorption can be reclaimed when colonic bacteria ferment these maldigested foods. Gastric acid suppression and electrolyte monitoring are critical. How is it managed? Although oral rehydration and antidiarrheal agents are used, many will require parenteral nutrition. Enteral nutrition is encouraged to stimulate bowel adaptation. Long-term complications include catheter-related infections, liver disease, SIBO, and micronutrient deficiencies. Intestinal transplantation can be performed especially in children. Eulactose, malabsorption, IBS, assignment. Input 5, Constipation Overview. A 42-year-old woman is evaluated for new-onset constipation that has progressively worsened over the last 3 months. She previously had normal bowel habits, with an average of 1 bowel movement per day. She now has 1 bowel movement every 4 to 5 days with decreased stool caliber. She has not had problems with hemorrhoids before, but she has noticed blood on the stool in the last month. She denies pain with defecation. She has had no change in her diet and has not started on any new medications. She has not had weight loss. She has a history of hypothyroidism for which she takes levothyroxine. There is no family history of colorectal cancer or polyps. On physical examination, BP is 110/70 mmHg and PR is 72/min. Abdominal examination is normal. External anal inspection is unremarkable. Andre, resting and squeeze tone are normal, with normal relaxation of the pube rectalis with stimulated defecation. No masses are palpable. The examination finger reveals blood streaking. Laboratory examination including full blood count and glucose, calcium, TSH levels, are all within normal limits. Which of the following is the most appropriate management? Begin fiber supplementation. Check serum free thyroxine levels. Perform anorectal manometry. Perform colonoscopy. Perform stool GIAC testing. Characterization can be viewed in terms of frequency in stool production, stool consistency, and effort required for defecation. Causes include metabolic, hypothyroidism, hypercalcemia, diabetes mellitus, pregnancy, structural, colorectal cancer, strictures, hernias, mass lesions, endometriosis, retrosil, dyssynergic defecation, medication-induced, opiates, TCAS, iron, CCBs, aluminum and calcium-containing antacids, antipsychotics, neuromuscular, intestinal pseudo-obstruction, spinal cord lesions, multiple sclerosis, autonomic neuropathy, Hirschsprung disease, colonic inertia, inflammatory, radiation, IBD. Functional, IBS, toxicities, bismuth, lead, herbal supplements. Evaluation and diagnosis. Time of onset, stool frequency and form, alarm features, weight loss, rectal bleeding, sudden change in bowel habits, family history of colorectal cancer, onset greater than 50 years, new medications, dietary changes, altered activity level, other gastrointestinal symptoms and effort with defecation should be part of and is helpful in making an impression. Physical examination is of paramount importance. Baseline laboratory studies include a full blood count, TSH level, serum calcium, and FBG. Patients older than 50 and those with alarm symptoms should undergo colonoscopy. Anorectal manometry for patients with features suggestive of dyssynergic defecation. Management. Treat reversible cause. Adequate fluid and fiber. Polyethylene glycol is more superior to other osmotic agents such as lactulose. Magnesium-containing antacids can be used but should be avoided in patients with CKD or hypermagnesemia. A stool softener such as docosate sodium can be used as adjunctive therapy to ease evacuation in patients with hemorrhoids or hard stools. Stimulant laxatives, such as bisacodyl and senna, may be considered in patients with slow transit constipation. Lubiprostone, a chloride channel activator that increases intestinal fluid secretion, can be used in patients with constipation predominant IBS or chronic idiopathic constipation. Bowel obstruction should be ruled out first. Methylnaltrexone can help with opiate-induced constipation without negating the benefits of the analgesia. Obstruction should be ruled first. Patients with dyssynergic defecation should be referred for biofeedback. Subtotal colectomy is reserved for patients with refractory constipation after dyssynergic constipation is ruled out and motility consultation has been completed. Input 6, Acute Viral Hepatitis. Viral hepatitis, background, systemic infection affecting the liver. Almost all cases are caused by one of 5 viral agents: hepatitis A virus, HAV, hepatitis B virus, HBV, hepatitis C virus, HCV, HBV-associated delta agent or hepatitis D virus, HDV, hepatitis E virus, HEV. Hepatitis A. What is the A genetic material? Single-stranded positive sense RN. Incubation period 14 to 28 day. Replication is limited to the liver, but the virus is present in the liver, bile, stools, and blood during the prodromal and ictery. When do you expect shedding in faces, viremia, and infectivity?